فلو كده خليها، يعني اطلبوا لوكال. دكتورة ديما، انا عملت الكوهوست بقى، يعني ادمنت
تمام
انت
تمام
بقى الناس.
دكتور. تمام، يعطيك العافية.
ربنا يبارك فيك. امتحنتي النهارده امبارح؟
امتحنت.
يلا خير خير.
إن شاء الله خير.
موفقين ان شاء الله. النصيحة بس اللي اقولها للكل: محدش يراجع، محدش يراجع، لا حلو ولا وحش. يعني الصفحة اللي خلصناها ما نبصش عليها تاني، نبص على اللي قدام. محدش يراجع. ايفن حتى بعد ان شاء الله امتحان الاورال ما تراجعوش لغاية لما ربنا يكرم بالنجاح. جمعوا الأسئلة وادوها بقى ايه يعني لزمايلكم اللي بيشرحوا، عشان ايه الناس تستفيد يعني كده. اوكي، يلا ليتس ستارت. بسم الله. كان حد طلب المرة اللي فاتت رنين، فاحنا هنعمل ايه حاجتين كده ورا بعض: اكسرهاية ورنيناية. وواحد وكانديد التاني اكسرهاية ورنيناية، وهكذا. تمام. اوكي. أوكي. بسم. مين الفيرست وان؟
Yes, sir, I
بس
can start.
اوكي يو كان ستارت يا بوس. جاست مينيت. اوكي،
I'm,
بروسيد يا
present,
بوس.
I'm presented with frontal chest radiograph of skeletally immature patient, a child. Presented, I can see there are multiple bilateral uh, fractures seen involving the posterior aspects of the both bilateral ribs, on multiple stages of callus formation at different ages. There is no pneumothorax. Although in my routine practice, I will magnify the image to check for the pneumothorax and pneumodiasternum. There is no pleural effusion. The upper abdomen looks normal. There is no pneumoperitoneum. Both humeri and the clavicle and the mandible looks normal with the appearance of ossification center. So this patient, I think, within 8 or to 10 or 12 months. So in this setting, I'm worried of this patient. I'm worried about non-accidental injury. In this case, this is an emergency case, and I will pick up the phone and inform the child protection services and also the child protection on the ward, in the pedia ward as well. And also I will request a skeletal survey, complete skeletal survey for the skull, both upper and lower limbs, and also the spine, for further evaluation of this patient. And also I will check the history related to this patient, and I'll ask also another consultant, a pediatrician or pediatric radiologist, to also double check the images for further to exclude or to prove a non-accidental injury.
اوكي. سبوت ايمج.
This is
Just
another
one.
case.
Yes.
Another case.
Yes. Yes. Another case.
Okay, so I'm presented with an axial T1 weighted image of the neck on the mid-level. I can see there is a abnormal, well-defined intermediate signal intensity lesion seen centered at the left carotid space, displacing the carotid vessels and jugular veins anteriorly with no significant involvement, and also compressing the left sternocleidomastoid muscle laterally, abutting the medial aspect of the oropharynx. I would like to see the T2. The T2, it's high
Contrast.
signal.
Post
This is post
contrast.
contrast. Sorry, post contrast fat sat T1 axial slice. There is intense inhomogeneous enhancement of the lesion with display with compression of the carotid vessels and jugular veins. In this space, the possibility of schwannoma is high, so this could represent a vagus schwannoma. Second possibility would represent also a paraganglioma in this place. I would like to also to check the other sequences and the check for another lesion, if it's paraganglioma or schwannoma, because this multiplicity may be up to 20 to 30% in patients. So this.
What specific sign that may raise the possibility of paraganglioma?
If we have the pepper,
Salt and pepper.
salt and pepper dynasties within the lesion. So this signifies the signal voids and the hemorrhage within the paragangliomas.
Okay. If in this location, what type of paraganglioma?
So this could represent a glomus vagal tumor.
Okay. Because glomus caroticum or carotid body tumor cause splaying, not displacement.
Yeah.
Good يا boss. Good يا boss. Excellent يا boss. Excellent يا boss.
Thank you.
يعني ما شاء الله. I will comment on this image after the second candidate. The second candidate, who is me?
Yes.
Okay, proceed يا boss.
Okay, I am presented with the frontal radiograph of both femur. I can see diaphyseal spiral fracture on the right femur. This fracture is highly suspicious for non-accidental injury in the pediatric age group, especially if the patient is non-toddler. So in my routine practice, I will urgently contact the referring.
What do you think? He is toddler or not yet?
Non-toddler, because I cannot see the femoral head ossification center.
When it appears?
5 to 6 months.
Okay.
So in my routine practice, I will urgently contact the referring physician to inform about high susceptibility of non-accidental injury, and I will call the child protection service to keep the child in the department, and I will recommend for a skeletal survey for the patient, and also if there is another sibling in the home, I will recommend for skeletal survey for him also, and I will recommend also for CT brain to exclude the non-accidental injury of the brain and the skull, and I will recommend for reporting
what type of brain trauma or brain injury in that suspect non-accidental? Intraaxial, extraaxial.
If there is skull fractures in this age is suggestive. Also, subdural hematoma is suggestive for non-accidental injury in this age group.
Okay, ask for scroll.
I'm sorry, Dr. Ismail, can you scroll for me? Because I'm using data.
No problem, yeah, boss. Okay.
Okay, thank you. I am presented with axial images MRI study of the brain. This is the flare sequence.
Yes.
Yes, I can see suprasellar mass lesion, hyper intense.
In my routine practice, I will check till the last cut, okay?
Yes, this is the last cut. Yes,
routine words, okay?
Okay, I will back to the main abnormality.
Okay.
Okay, it is irregular shaped hyper intense lesion in the suprasellar region. The differential diagnosis would include suprasellar mass like meningioma or or pituitary macroadenoma. So in my routine practice, I will review other sequences to better localize the lesion and check the signal characters and also the pattern of enhancement to narrow my differential diagnosis. I will check also the coronal images to see the mass effect, if there is mass effect on the related vessels and the optic chiasm.
I'll show you the contrasts.
Okay, it appear hyper intense signal.
Yes. So now, what is your differential?
similar to the vessel signal. Could be vascular lesion. Like aneurysm, but less likely. And it could be also hyper-enhancing lesion like meningioma.
What hyper enhancing lesions may come in this area? meningioma واحدة فيهم. Okay, what else?
Meningioma.
meningioma needs dural base.
Yeah.
Okay, okay, so unlikely in this area. Okay, what else? craniopharyngioma adult type. Okay, اللي هو solid. Okay, what else?
Craniopharyngioma يعني usually more heterogeneous than this.
In adult form more homogeneous. Okay, and less cystic.
Okay.
Okay, glioma. Okay, more bilateral. Okay, what else? Look at the pineal region. You see anything here? Okay, I'll help with the sagittal. There is a lesion here and another lesion here. Huh?
Can you help me? Germinoma can be?
Yes. Okay.
Germinoma.
معلش بقى maybe some leg. Okay.
Yes.
It's bifocal germinoma. Bifocal germinoma. It's known to come in the hypothalamic area and on the pineal region as well. It will be homogeneous, intense, avid enhancing lesion. Okay. Check the retina. Very good. Because it may be trilateral or quadrilateral retinoblastoma. Okay. So we have to check both orbits. Very good, Yabos. And you can finalize the case. Now back to chest X-ray or pediatric X-ray in the exam settings. Any pediatric X-ray, please rule out non-accidental injury. It may be in the form of chest X-ray or skeletal X-ray. It may be just normal chest, and at the edge of the film, there is humeral fracture. Clavicle fracture is not considered nay. It may be related to birth trauma, but humeral fracture is considered. So please remember to look at the edges of the film. Posterior rib fractures, highly specific, but anterior rib fractures also may be suspicious as well. Posterior rib fracture or multiple fractures of different ages. Okay. So this is non-accidental injury from chest X-ray. From skeletal, the first comment should be about the age. Okay, it's X-ray of both femora and pelvis in skeletal immature or just a child. I cannot see the ossification center of proximal one shape. Yes, I'm sorry. Yes. Pineoblastoma, not germinoma. Yes, thank you. Pineoblastoma, that may be trilateral or quadrilateral, not germinoma. Thank you, Abbas. Not germinoma. Germinoma come in the hypothalamus and pineal region. Pineoblastoma come in pineal region and retinal, and also hypothalamus. Very good, Abbas. Okay, back again to this area. So the first comment about the age of the patient. I cannot see the ossification center of proximal femoral epiphysis, denoting it's less than 6 months. The ossification center here appear from 3 to 6 and has diaphyseal fracture. It's a spiral fracture type. In a non-ambulatory child, highly suggestive of non-accidental injury. Also, there is a hematoma causing swelling. If non-accidental injury, then I will immediately or urgently convey the finding to the referring physician. Immediately contact the child protective service. Keep the child in department and ask for skeletal survey, assess the brain either by ultrasound, transcranial ultrasound, or CT brain to detect any fractures, any subdural hematoma, and assess clinically for any abdominal or visceral injuries as well. The report should be done by two consultants, whether X-ray skeletal or X-ray chest. Another very important item in the exam about pediatric chest X-ray. Pediatric chest X-ray carries 4 safety issues. 4 safety issues. The first one, look at the bone for non-accident. Okay. What else? If preterm child, you cannot see the ossification center of humeral epiphysis. Okay, good. And there is endotracheal tube. Look for complications like pneumothorax, pneumomediastinum. Pneumothorax may be just very subtle in the form of deep sulcus sign or increased lucency as compared to the other side, or very sharp delineation of the cardiac border and diaphragm as compared to the opposite side. So this is chest emergency. So skeletal to exclude knee, non-accidental injury, and chest to exclude pneumothorax, pneumomediastinum. What else? Look at the density of the liver. The opacity of the liver nearly similar to the abdominal wall. No lucency overlying the liver shadow. No branching lucencies overlying the liver shadow. No pneumoperitoneum or portal venous gas. This is considered abdominal emergency. So we have skeletal, abdominal, and thoracic. The last one, misplaced lines and tubes. So if you face the chest X-ray in a pediatric age group, please first thing to exclude child abuse, then comment on lines and tubes. Okay, and in the chest, pneumothorax, pneumomediastinum. In the abdomen, pneumoperitoneum, portal venous gas. Okay, who is next? مين يا شباب؟ Next
And I
candidate.
continue.
I can go for another one. Back to candidate.
If no other candidates.
Okay, let's wait if it's other candidate appear.
Any other? Wow. Okay, continue, boss. Continue.
I'm presented with a frontal chest radiograph of skeletally mature patient. You can see there is abnormal opacity seen involving the left, mid, and lower zones of the lung. There is also abnormal mediastinal silhouette in convex opacity seen along the left side of the para-mediastinal strip. The left cardiac border is not delineated well, and there is also small linear translucent lines projecting down to the left diaphragm. There is vaunted of the left costophrenic angles. I'm checking the ribs. There is no underlying rib destruction. And there is no, and also.
Okay, where is the location of, what's the location of this lesion?
So silhouetting the left cardiac border, this must be in the anterior segment of the left lower lobe or in the mediastinum, because there is another opacity also projecting on the left side of the mediastinum. So this might be a paraspinal mass.
This may be aorta, okay? But regarding this one, anterior segment of lower lobe, which segment of in the left lung adjacent to the anterior located
this lingula
heart?
Most likely.
Yes.
The lingular, yes.
Okay, give me differential.
So in the setting of the patient, if has cough and constitutional symptom, this might representing an inflammatory process or could represent a neoplastic process. I would like to review the history of this patient and the old study if there is opacity is there before, and do a CT scan for further evaluation. Okay, I can scroll.
Ask.
Yeah.
Proceed.
I'm presented with chest CT and post-IV contrast. There is abnormal mediastinal lymphadenopathy in the paratracheal group. Paratracheal lymph nodes are enlarged, aortopulmonary and prevascular lymph nodes significantly enlarged. There is also some of the subcarinal lymph nodes are seen with necrotic centers, and also bilateral hiral lymph nodes. The previously described lesion in the chest is heterogeneously enhanced solid mass involving the lingula and also encasing the pulmonary vessels. There is also tumoral thrombus seen within the left. There is tumoral thrombus within the left inferior pulmonary vein and also in the left atrium. The left atrium itself is infiltrated also, I think. Can go down. There is thrombus or tumoral thrombus within the left atrium. And also there is invasion of the mediastinal.
And also a thrombus into the right pulmonary veins as well.
Right pulmonary veins. And also there is invasion of the mediastinal fat with compression of the bronchus of the left main bronchus. So in my routine practice, I will check the pulmonary window as well to see if there is any pulmonary nodules or any metastasis. I will also checking the adrenal glands for any deposits. Also checking the bones for any deposits.
This is the first paragraph or the first point. I will comment on the all slides first.
Yes.
Because you may miss adrenal metastasis, for example, or hepatic metastasis.
Yes.
So please, any cross-sectional imaging, just say I will take a general look first. Okay, the main abnormality is 1, 2, 3. Okay, just a minute, please. I will accept the recording. Okay, continue your course.
So there is no abnormal deposits seen on the both adrenals. There is subtle small hypo-dense lesions on the layer. It looks like cysts, simple cysts. Checking the bones as well. So this patient is presented with a T4. This is more than 10.
Okay, it's advanced. Okay,
advanced cancer.
likely
Yes.
stage 4. Okay,
Yes.
and
Stage 4 disease with multiple lymphadenopathy.
And also it's pleural based and pericardial based, with no line of fat in between. Okay.
So in this case, this patient needs further discussion on the further. I will do first the abdomen and pelvis for further staging of the disease, and also it needs to be referred to the MDT chest oncology team for further management and treatment.
Okay, Abbas. Okay. Another patient, proceed.
I'm presented with axial T1 weighted image of the brain. This is the last one.
Yes.
So you can see there is abnormal lobulated outline, a high signal, hyper intense lesion seen, centered at the left cavernous sinus, encasing the left cavernous portion of the left internal carotid artery. And also I can see also the abnormal droplet of high signal densities within the left sylvian fissure as well. So this could represent the suprasellar dermoid or cavernous sinus dermoid cyst, ruptured dermoid cyst with chemical with the infiltration of the subarachnoid space. I would like to confirm that on T2 and the axial T1 fat set sequence to check for the fat.
Just
and
a
also,
minute. Any differential diagnosis for high signal intensity lesion in this area?
In T1, it could be hematoma or organized hemorrhage. Other possibility could be melanine deposits in the T1.
Good. طبعا هي extra axial. It's primary extra.
Yes.
Okay, this is the fat set.
So in the fat set is complete suppression of density on this image, and also I will check the lesion on the left sylvian fissure. It also shows also suppression. So this represents the fat So this is a ruptured dermoid cyst and with droplet seedling on the
Okay.
subarachnoid space, and this has to be referred to the neurosurgery team.
This is the difference between the aneurysm and
Aneurysm, yeah.
yes, the aneurysm has a peripheral signal void, and if you notice, there is continuity with the internal carotid itself. Okay. Very good يا boss. Another candidate.
ممكن أنا؟
اتفضلي يا فندم، يا نهار ابيض.
شكرا.
Okay, and differentiate between lipoma and dermoid. Lipoma is unlikely. Lipoma will be very pure and unlikely to be ruptured. Dermoid is by far يعني common in this area. Just a minute, I will remove it as annotation. ما حدش يشخبط يا شباب، ما حدش يشخبط. Okay, okay, proceed us.
I'm presenting a case of left shoulder radiograph. I can see density abnormal opacification of the acromion of the scapula, abnormal medulla. Regarding
No,
to
يعني
لا
till now scapula is good.
I can't nothing catch my eye, so I will check details. Soft tissue seen normal. There is no abnormal soft tissue opacity. Then the bone, the vertebrae. I am checking the vertebrae, so I can see a normal spinous process and medullary density. Also the ribs, no fracture lines, no. I can't see. I want to check if there is pneumothorax, but there is. I can't see
Good.
pneumothorax.
Okay, so it's
also-
normal.
Actually,
brought a
I
normal
feel it's
case.
normal. لا بس no, it should not be. I'm so lucky.
No, a normal appearing shoulder radiograph
Mm.
or normal appearing cervical spine radiograph. Comment on the visualized part of the lung and the related ribs. First rib, second, third, fourth. You see or
Fifth.
no? Yes, yes,
Fifth rib osteolytic lesion.
yes, yes.
Oh.
Here, complete rib. Here, complete rib. Here, it's destroyed. I can't see the cortex. So sometimes we see rib destruction, we see nodule, we see hilar mass, we see apical opacity, or even supraclavicular soft tissue swelling. Also comment on the widening of acromioclavicular joint. So normal appearing shoulder radiograph, look for hidden areas, occult pathology. Normal appearing cervical spine, the same pathology. Okay. Good يا boss. I will show you now. This is the chest X-ray of the same patient.
Now
You
it's
see
very
it's
obvious.
yes, it's clear now. Okay. MRI trauma. عندك لابتوب؟
أيوة.
Okay, ask for control.
الكنترول منين؟
طب
ثانية.
اتفضل. اوكي يا بص.
I'm presenting MRI brain case T1 weighted image. I'll take a look in the study. It's the study. Okay. There is,
Tricky again. Normal appearing MRI. My target in these cases to just show you the hidden areas. Okay. Look
okay.
at the hidden areas in a trauma. Where to look and what to look for.
Should be bleeding. So
Okay. Okay.
bleeding
If massive
also
bleeding, easily to be seen.
to
But
be seen.
sometimes diffuse axonal injury. So
diffuse
look up. Look up.
up.
If anything.
Up.
Okay. Here, no, nothing. Sometimes subarachnoid hemorrhage. Sometimes cortical vein thrombus. Okay. All these are occult or hidden areas. Now look down at the vessels and tell me any abnormality. Down. Yes.
There is yes, there is abnormal hyper intense signal is seen in the common carotid in the left internal carotid artery, involving the intracanalicular part, the
Go
cavernous
down.
part.
It's a trauma. Maybe
maybe there is
yes.
in this case
Yes.
yes, there is this section of
Yes.
the section of the carotid of the distal part of the internal carotid artery. In my routine practice, I will do MRA for the neck as well to check the extent of the
very good,
section.
Very good, very good. The section may affect okay, this internal carotid, and this offside may affect internal carotid, may affect the vertebral. If the patient has a trauma and a neurological manifestation. Best sequence T1 with fat set. But still in T1, I can see the mural hematoma, high signal, and causing narrowing of the caliber, reduce the caliber of internal carotid in this area, and above, it's nearly thrombosed. Okay, so again, hidden areas in MRI of the brain. Maybe small lesion in hypothalamus or sellar. Maybe vascular lesion. Maybe mastoid, opacity in the mastoid, internal auditory canal, small lesion in the internal auditory canal, or high up cortical vein thrombosis, subarachnoid hemorrhage, diffuse axonal injuries. These are hidden areas. If normal appearing MRI brain, look at these areas. Okay, very good, يا boss. Very good. Any other candidate? ها؟ حد تاني يا
Yes,
شباب؟ Okay,
yes.
proceed.
Okay. I presented with frontal chest radiograph of child patient. I cannot see ossification center of humor. This immature child, I can see multiple tubes lying. I can see multiple tubes. This is a very sick patient, ICU patient. I would like to check this tube is central line in not in adequate position. It is
Where is the central line?
this is external tube or
Yes. Here there is a tube through the mouth. Then stop here.
it is yes. This is NG tube in higher. It is NG tube calling up in the upper esophagus. The upper esophagus. I see there is
Which means
means esophageal atresia. I can see there is gases within the bowel. I would like to check vertebral for any vertebral anomalies. I can see there is segmentation of vertebra. In my routine practice also, I check lateral view. I would like to check.
This may be due to rotational effect. So maybe segmentational, maybe rotational, but good,
Maybe.
good.
Okay.
Good.
I would like to check also upper limb for any.
Okay. What is the explanation if this is esophageal atresia? Why there is gas in the stomach?
This is esophageal atresia associated with fistula. It is associated with
Esophageal fistula. Okay.
Fistula.
Okay.
This is vectoral. It could be associated with vectoral anomalies. I would like to confirm my findings to refer physician and request ultrasound abdomen to rule out renal anomalies and echo for cardiac anomalies.
Very good.
And look for atresia, intestinal
And
atresia.
skeletal survey. Okay. You have laptop?
Yes, yes.
Okay. Ask for control. Okay. Comment يا boss.
Okay, presented with frontal, with axial MRI brain T2. I would like to take general look before I start my comment. I'm scrolling to see there is large mass seen at the area suprasellar area encasing both carotid vessels.
Sellar or suprasellar for both?
Sellar and suprasellar area.
Okay.
Encasing carotid vessels shows intermediate signal in T2 and extend posteriorly to the
Peripontine system. Okay.
peripontine system, extend posterior to peripontine system, and anteriorly to sphenoid sinus. I would like to check
anteriorly into nasal cavities. Okay. Okay. And inferiorly through cavernous sphenoid sinus. Okay.
Sphenoid sinus. In my routine practice, I check the remaining of sequence and request and see sagittal image to further localization of this mass.
Any differential?
Contrast study. Differential of this aggressive mass lesion. It could be
you mentioned the center is sellar and suprasellar. What invasive lesion come here?
It could be a macroadenoma.
Yes, yes. Good. Macroadenoma, pituitary macroadenoma. Okay, what else?
It could be metastasis.
Okay.
Nasopharyngeal carcinoma, but the
unlikely from this location. Okay, yes. Okay. Yes. What meningioma? Parasellar meningioma.
Parasellar meningioma.
Okay, but there is no hyperostosis of the related bones. Good, good, yes, good, yes. Just leave the mouse, leave the mouse, leave the mouse.
Okay.
نحاول ايه اجيب لك الساجيتال ده اللوكيشن بتاعها. What if this lesion is a high signal intensity in T2?
High signal intensity in T2, it could be chordoma.
Very good, very good, very good. Very good. Okay, just okay. تسلم يا boss. Another friend.
Can go again.
Yes,
okay,
yes,
go on.
Yes, doctor, I'm with you. This is a chest X-ray point of view of a skeletal mature patient. Demonstrate there is a left upper lobe cavitary lesion, multiple cavitary lesion with a mild thickened wall. Seem to be arise from the extension to the left hilum. No normal cardiac shadow, normal cardiophrenic angle on both costophrenic angle. Normal bone density seem to be soft tissue density. The first differential diagnosis on the report the cavitary lesion in the left upper lobe, follicle infectious cause, tuberculosis. Another cavitary lesion to cause this thick wall, ancillary, and no associated with infectious cause. I put the bronchoalveolar carcinoma. Can I get
unlikely يعني it's a classic for TB due to retraction
TB?
of the
Yes.
hilum, yes, and
Retraction of the hilum and
reticulation.
cavitary lesion, yes,
Okay.
and involving the left upper lobe. This axial section CT scan of the chest pulmonary window demonstrates there is left upper lobe cavitary lesion with thick wall associated with a tree in bad appearance, distributed in both lung field, more on the left-sided, and multiple pulmonary nodules, more distribution in the left hemithorax. Can I see the lower pool for this?
Okay.
Yes. And not involving the lower lobe of both lung field. For my routine practice, I refer this patient as TB, pulmonary TB, referred to the
now
and
all of us please concentrate.
yes.
You will tell me the comment. If a tuberculosis with
Yes.
this pattern, how to manage?
Active, yes. Isolated
Yes.
asked for isolated the patient and screening for his family, and send for Suprasellar, and ask to refer to his doctor to do the anti-TB drugs.
Okay.
يعني active TB لأن هو tree in bad appearance mean this is active TB.
Okay. It's reticulations, by the way. It's reticulations rather than cavitations. Cavity here, I see here small cystic lesion, but it's predominantly reticulations and retraction of the hilum. The cavity is well seen in CT, not in X-ray. Okay, good يا boss. Okay, another case for you. Just a minute. The easy case. You don't have laptop as usual,
No.
right?
No,
okay.
yes. Thank you.
No problem. Okay, from down up.
Yes, there is any history or not?
A child with neurological symptoms.
Yes, this is MRI of the brain, a T2 weighted image, axial section. There's demonstrate multiple small vessels distributed through all the brain, both cerebellar hemisphere, especially in the basal system. I want to look the internal carotid, both internal carotid artery to see if it's patent or not.
Very good.
Can I see? Yes. The right one seem to be attenuated bilateral. Yes, attenuated
bilateral, yes.
bilateral attenuation.
Very good.
And this multiple vasculature goes with Moyamoya disease. I want MRA for further evaluation for brain vasculature.
Very good, yeah, boss. This case of bilateral occlusion of attenuation with puff of smoke.
Of puff of smoke, Moyamoya disease. Yes.
Okay. اللي احنا هنشوفه يا شباب just the signal point of the collaterals.
Yes.
Too small, too many. And
Signal
if we go, yes, a signal point. And if we go to the internal carotid, highly attenuated or nearly absent. Okay. And replaced by this amount of collaterals. Very good, Yabus. Very good. I think we have the NG with the classic.
Cup of smoke, classic pattern for it.
Puff of smoke. Excellent.
Doctor, this is NGO for the same case?
The same case.
Yes, but okay.
Okay.
A single area. Okay.
لا ماشي comment. Okay. Comment.
Okay.
Okay. Puff of smoke. Yes. Angiographic term. طيب another candidate يا شباب. اعذروني على فكره انا قاعد دلوقتي قاعد اكل واشرب وانا بكلمكم لان انا في البرايفت ودي الساعه الريست فسامحوني بقى
Ismail.
الكونسنتريشن
Yeah.
مش زي الايام اللي فاتت، سامحوني والله.
No, no.
الله يعينك.
Well, very helpful
ربنا
for
يبارك
you.
فيك. ربنا يبارك
Thank you.
فيك.
Shall I start, Dr.
اوكي،
Ismail?
اتفضل يا باشا، اتفضل. جون.
Presented with the frontal abdominal radiograph of a child. You can see there is abnormal displacement of the upper small bowel or upper bowel loops to the right side by homogeneous opacity seen projecting at the left side of the abdomen and left flank region. I'm checking if there is any underlying rib destruction or any vertebral bony lesions. The pelvic bones looks normal. There is no free gas within the portal tracts, and there is, I guess this is a supine film, so there is no signs of pneumoperitoneum as well. So this might present an enlarged, the first possibility in this age group, the first possibility would be an enlarged kidney like hydronephrosis. Second would be a tumor like renal tumor or adrenal mass. I would like to go further for ultrasound first of this patient and then MRI.
جود جود. يبقى احنا عندنا ايه الكلو الاولاني we should start with the mass itself not the effect. We have here a left sided soft tissue, a large soft tissue infection or soft tissue lesion causing displacement of the bowel filled with gases upward and laterally. It doesn't extend to the pelvis. No differential denises, no calcification, and the differential diagnosis as our doctor mentioned. We will complete now. It's preferred to start with CT or
Ultrasound and then MRI.
Ultrasound, definitely ultrasound, because this is a safety issue. Ultrasound showed a mass, no problem to start with. The next will be CT or MRI. Okay, but ultrasound first. What you see here from ultrasound, just a few cuts.
I'm presented with a CT abdomen and pelvis portovenous phase of the same patient. I see there is large heterogeneous retroperitoneal mass involving the left kidney with the close sign. So this originating from the left kidney. I would like also to check the pre-contrast study to see if there is any calcification. I can see there is tiny small calcification maybe presented within the mass. The mass is displacing.
Not sure about calcification in the post-contrast. Okay. We should confirm في البريف. Okay.
And then the kidney, the remaining kidney or remaining part of the kidney is displaced in the midline, was compressed to the right side. So in this patient, this is a Wilms tumor. I would like to see also in my routine practice, I will check the whole study in thin slices to check if there is any renal vein invasion. I would like also to check for any lymphadenopathy. There is no lymphadenopathy here. I check also for
aorta, abdominal aorta is not encased.
Is not encased, so this is ruling out neuroblastoma.
Good.
And also there is no
proper location against the spine, not elevated. Good.
So this patient needs further staging, first with a chest and abdomen, chest and pelvis to see the involvement of other organs as well, and needs to be referred to discussion on the MDT oncology, the pediatric team.
Okay, proceed يا boss.
I'm presented with a sagittal T2, T2 weighted image.
Are you sure it's a T2?
No, I'm not sure.
Look at CSF.
It's the T1. Yeah, T1. Sorry.
Yes, look at CSF,
T1,
especially at the sternum.
Yeah, it's the T1 sagittal image of the cervicothoracic spine with abnormal low signal intensity involving all the vertebral body of the cervical and upper thoracic vertebrae. So there is abnormal bone marrow process involving the hole, also involving the posterior element and the transverse and spinous processes as well. There is no paraspinal masses seen or pre-vertebral soft tissue lesions. The patient is young. There is no significant degenerative changes. So this might represent an infiltrative marrow process. Second possibility would be a hemochromatosis. I would like also to check if this patient has previous study for abdomen and pelvis to check for the iron deposition within the liver, or this patient might also have a thalassemia, and this could be replacement also of the bone marrow. Other possibilities would also include a lymphoma or leukemia. Although it's not very classic, in the T2, there is also significant reduction of bone density below the, I'm trying to scroll down. And there is no, I'm checking the other side.
This, I think the liver as well, very low signal intensity.
Yeah, and the liver also, I'm checking the other side for the spleen, although I would review in the axial cuts as well. But if the liver and pancreas are involved, so this might be presenting a primary hemochromatosis. And if it's not involved, and also the spleen or the spleen and liver without involving the pancreas, so it could be secondary hemochromatosis due to thalassemia or any other cause.
Very good, Yavuz. Very good. This case actually tricky for those who don't concentrate on the spine. I show now, this is the normal marrow signal in T1. In T1, the marrow contains fat. So it's expected to be higher intensity, more bright than the disc in T1. Okay. Now, this is T1 of our case. The marrow is very dark, very low signal intensity in the all imaged vertebrae in a homogeneous or uniform pattern. No degenerative changes. This is most likely a child or a young adult. So think in hemochromatosis, like thalassemia, for example. Okay, if older age group, maybe myelofibrosis. If older and degenerative changes and non-uniform, maybe sclerotic metastasis as well. Okay, so so this is a case, I think, of thalassemia. Okay, thalassemia, yes. I think we have two remaining candidates. Who will be with me? Trauma.
Can go to
Okay, go on. Trauma.
Frontal chest radiograph of skeletal mature patient. There is abnormal veiling of the left hemithorax with abnormal widening of the superior mediastinum. Cannot see the aortic silhouette well. So this might represent, instead of trauma, this might representing acute traumatic aortic injury. And this patient needs an urgent CT angiogram, CT aortogram, for further delineation of the aortic injury. There is no pleural effusion on the left side. The right side looks normal with some mediastinal shift to the right side and tracheal shift also to the right side. So it must be a hematoma or left apical lesion or hematoma within the pleura. So this patient needs an urgent, according to his hemodynamically, if he's hemodynamically stable, I would proceed for CT angiogram of the aorta to further check for any aortic dissection or aortic hematoma or any acute injuries.
Excellent, Yavuz. Chest trauma, the most important safety issues, dilatation or widening of the mediastinum with inconspicuous aortic knuckle. I cannot see the aortic knuckle. Most likely mediastinal hematoma, either from venous injury or aortic injury. It's a high emergency. What else? Of course, pneumothorax. What else if multiple rib fractures at multiple sites? Flail chest. Okay, what else if diaphragmatic injury? All these types can be life-threatening. So it needs emergent conveys to the finding, and of course CT scan. You want to comment on CT? Just in brief.
CT, in the angiogram, I can see
Okay.
there is abnormal contour of the aorta. There is also leaking contrast on the posterior aspect of the aorta. This is significantly aortic traumatic dissection with high attenuated left-sided pleural effusion representing left hemothorax. There is also mediastinal hematoma, and the hematoma extending to encase the left subclavian artery and anteriorly displacing the trachea. And this patient is an emergency, of course, and these findings should be conveyed to the cardiothoracic surgeon and on call
تمام
for further evaluation.
اوكي. فهنا يعني مدلعينه، بس بيقول لك ان في سودو انوريزم كده عند
Pseudo
الجزء
aneurysm, yeah.
يس اتس اوكي. جود ديسكريبشن. اوكي. يس بروسيد with this case.
I'm presented with a I'm presented with a sagittal MRI T2 scan of skeletal hematuria patient. There is abnormal dural ectasia seen involving the lower lumbar vertebrae with scalloped posterior aspect of the vertebrae. There is no obvious low attenuated solid lesions seen within the cystic spaces. Cystic spaces also extended to involve some of the neural foramen at the L5S1. And so in this context, these findings could representing dural ectasia in a patient with neurofibromatosis. I would like to see the axial scan first.
What are the differential diagnosis of posterior vertebral scallop?
It's if not in this case, of course, but in the other cases could be acromegaly, mucopolysaccharidosis, achondroplasia, or any intradural masses compressing the dura could represent also.
So you mentioned here it's CSF-like.
CSF-like cystic, and there is no conus lesions.
Okay. What other sequence do you want to see?
T1 post contrast.
T1 post contrast. Okay.
Okay, so T1 post contrast. There is now abnormal, heterogeneously enhanced lesion,
huge elongated
mass, yes, involving the cecal sac with scalloping of the posterior aspect of the vertebral bodies. So in these findings could represent the intrathecal mass. For differential, it could be a intrathecal lymphoma or just leukemic infiltrates.
What is the lesion that may arise from the end of the cord?
Could be myxopapillary ependymoma, but there is no hemosiderin rim here. I don't see.
But still, one of the on the top of the list.
Just a minute. Very huge, very huge.
Yes, it's okay. Accept it. I'll show you now the T2. Look here, this CSF surrounded the cord. There is little differences between this very high signal and this signal. Okay. So it's not classic CSF. Okay. And
to try to be on the safe side, to request also the post T1.
Yes. Post contrast will be very helpful. But from T2, you put a good differential diagnosis. Okay. I think here differential diagnosis is here. The first spinal cord tumor like ependymoma or others. Achondroplasia, acromegaly, mucopolysaccharidosis, Marfan syndrome, osteogenesis imperfecta, and of course, dural ectasia of neurofibromatosis. Okay. Another question before we go. Differential diagnosis of anterior vertebral scalloping.
Anterior vertebral scalloping could be due to any enlarged anterior prevertebral mass like aortic aneurysm, or prevertebral abscess, or neoplastic process involving the anterior aspect of the vertebrae. Congenital anterior
Down syndrome.
Could be due to lateral meningocele.
Down syndrome.
Down
Okay.
syndrome.
So anterovertebral scalloping like this one, aortic aneurysm, abdominal aortic
Aortic
aneurysm,
aneurysm or masses.
lymphadenopathy in general, whether leukemia, TB with abscess, congenital as Down syndrome. Very good يا boss. The last candidate, last 2 cases. ها مين عايز يفنش؟
ايوه بس
اوكي.
Yes.
اوكي طيب we have to one for you X-ray and one MRI.
Okay.
ها اوكي.
Okay. And the second one. Okay.
اوكي اوكي. ها proceed يا boss.
انا ولا الدكتور؟
اتفضل.
Okay. I am presented with the frontal abdominal radiograph of an adult patient. I can see soft tissue density in the left side of the abdomen. I am trying to delineate the psoas shadow, but I cannot detect.
Good.
In my routine practice, I will zoom the image to be sure about the obliteration of the psoas shadow. I can see no bowel gases in the left side of the abdomen, and most of the bowel gases are seen in the right upper quadrant. So I am suspecting mass lesion on the left side of the abdomen. With this obliteration of the psoas shadow, I am suspecting retroperitoneal mass. If the patient presented in acute setting, I am worried about the possibility of ruptured aortic aneurysm or retroperitoneal hematoma. If not in acute setting, I am suspecting retroperitoneal neoplasm. So in my routine practice, I will correlate with the previous history of the patient, and if any related previous imaging, I will check. And I will take the patient further by CT abdomen with contrast.
Okay, good. Another items to describe here: no curvilinear calcification that's seen with aortic aneurysm, no vertebral destruction seen with vertebral osteomyelitis, Pott's disease, and cold abscess. Okay, just يعني part من الديفرنشال. What you see here?
Okay, this is the CT study of the same patient. I can see aneurysmal dilatation of the aorta, and I can see retroperitoneal mass lesion with infiltration of the fat planes on the left retroperitoneal region. Signs are highly suggestive of ruptured aneurysmal aorta. So in my routine practice, if the patient is hemodynamically stable, I will proceed for CT angiogram of the aorta. If the patient is unstable, I will recommend for resuscitation of the patient and shifting urgently to the surgical vascular surgery team for rapid management.
Sometimes you see the aortic aneurysm with contrast. This would be in the form of mural hematoma. Without contrast, it will be hyperdense hematoma also. But in post-contrast, hypodense. Okay. Last case for Doctora. Oh,
Yes,
it was
doctor, with you.
CT, but not MRI. Yeah, you have a scroll, or I will.
With you. For you.
Okay.
Okay, thank you.
Okay. الله يكرمك يا ابو عبد. تسلمي
Okay.
تسلمي يا فندم.
Thank
تسلمي.
you.
لا مؤاخذة دكتور.
Axial.
اوكي. اتفضلي يا فندم. اتفضلي.
ممنونة من عندك دكتور، شكرا جزيلا.
اتفضلي. اوكي.
Axial section CT scan of the chest, mediastinal window with IB contrast demonstrate there is. Can I see the upper loop? Yes.
Okay.
Thanks.
I will get it from.
Thank you.
Wow.
Sorry. So yes. From above there is multiple collateral
Very good.
vasculature seen in
Very good.
the anterior part of the chest wall and
Good.
in the distal of the neck, associated with large homogeneous intense mass that encasing the most of the large mediastinal vessels. I not seen the superior vena cava. mean to be thrombosed because of presence of this mass. I wanted to see if there's seeking for lymph nodes associated for this large mass.
Yes.
Yes, this is,
Highlight.
maybe this is subhilar lymph node and subcarinal lymph node also.
Good. Very good. Very
Yes.
good. What else here?
Yes, this reflex of the contrast through the
Good.
IBC and the liver, and this lesion in the liver take the contrast called the quadrate lobe, hot quadrate
Yes.
lobe. This
Yes.
goes with the superior vena cava obstruction.
Yes, excellent. This is also called the pseudo lesion of the liver.
Pseudo lesion, yes,
Yes,
pseudo lesion
yes,
of the
yes.
liver. Totally, I keep my comment of this case. This is case of the mediastinal lymphoma with encasing of the large vasculature lead to superior vena cava thrombosis.
Just a minute.
Yes,
Lymphoma
yes.
causing superior vena cava obstruction.
No, sorry.
Lymphoma doesn't occlude vessels.
Yes, not
okay?
include the vessels because
Yes.
it's gelatinous mass. Yes.
Yes.
This case of a small cell carcinoma, mostly to be invaded the vessels, causes severe vena cava obstruction and reflex of the contrast to the liver
or
collateral.
invasive thymoma. Either bronchogenic carcinoma if it has the main component in the lung. If it has the main component in the mediastinal like this, it may be
invasive thymoma.
What if there is a calcification in this mass?
Called mediastinitis.
Very
Radiation
good.
mediastinitis.
Fibrosing
mediastinitis.
Which caused by?
Caused by radiation, caused by previous infection, caused by lymphoma, malignancy, multiple causes, previous TB, histiocytosis, sarcoid.
So this is a case of superior vena cava obstruction
caused by mass. Yes.
Yes. This is.
I refer this case for referring doctor to do a biopsy and staging of the cases to do abdomen CT or PET scan for further evaluation and biopsy.
Excellent, يا boss. Excellent, يا boss. Thank you, my friends.
Doctor, final diagnosis: thymoma, invasive thymoma.
Hepatic pseudo lesions. He didn't write it, but in a mediastinal lesion, I will think in invasive thymoma, not lymphoma. Lymphoma usually causing floating vessel sign. It's around the vessels. It doesn't occlude the vessels. Okay.
Yes.
This is most likely thymoma, invasive thymoma. Okay. Thank you all. معلش بقى يعني.
Thank you so much, Dr. Ismail.
Welcome. هي جت سريعة بقى معلش. Okay. Welcome. See you tomorrow إن شاء الله.
Same time, Dr. Ismail.
Same time. ما هي my break time is from 6 to 7. Okay.
Okay. Thank you. Thank you.
السلام عليكم. السلام عليكم.